Good morning, good afternoon, good evening, everyone. Welcome. We are just going to wait just a minute or so to let people join, and then we'll start officially. Great. So, good morning, good afternoon, and good evening, everyone across the world. We've seen many people joining us already, and it's my pleasure to welcome you to today's webinar, More Health for Today's Money, and particularly how can district managers strategically resource primary healthcare today to get more health for their money. Before we really get going, I'd like to go over just a few logistics on this Zoom platform. So today we will not have a live Q&A session, but we do have two opportunities for you to engage with the whole group here. First of all, please feel free to use the chat. You can send a chat to everyone and introduce yourself. If you have reflections or comments during the webinar, you could also put a comment there and we will be tracking those. You second can use the Q&A box for any particular questions that you have for panelists. We will try to answer some of these in that Q&A function itself during the webinar, and others that we can't answer we'll track and record and follow up after the webinar. If you're not seeing a screen like the one shown here with the Q&A and the chat buttons at the bottom, you should be able to click More a little bit over on the right-hand side, and hopefully that will pop up the Q&A and the chat functions. Great. So going ahead, welcome again to this webinar series. My name is Nathan Blanchette, and I'm a Program Director at Health Systems Insight. Some of you may know us by our former name, ThinkWell Institute. And I'm very excited to kick off this webinar series and today's webinar in particular. This is part of a four-part series that has been organized by our Strategic Purchasing for Primary Healthcare program, with thanks to the generous support of the Gates Foundation for our project. I will start today's webinar with some opening framing comments, and then we'll be moving on to two exciting panels. Next slide, please. So a little bit of context to start, and that is something I'm sure we're all aware of, the tightening health financing as primary healthcare demands grow. This is really a major motivation for this webinar series, and we see this tightening sort of coming from three sources. First, many governments face rising fiscal pressure from debt. The World Bank, for example, has reported that low and middle income countries paid a record $1.4 trillion in debt service in 2023, which we know directly squeezes budgets for health. The World Health Organization, meanwhile, has reported that following a temporary surge during the COVID pandemic, health spending has declined across all income groups. And I'm sure we're all aware in the news just very live today that geopolitical instability also adds to rising energy costs, rising uncertainty. That tightening comes at the same time as a decline in external health financing. So again, to cite the World Bank, they're projecting that combined government and donor health spending will decline by 2030 in 80% of low and middle income countries and 40%, sorry, 80% of low income countries and 40% of lower middle income countries. That leaves the projected shortfalls in meeting universal health coverage goals that you see in the chart on the right. So on the left-hand side of the chart, you see projections for low-income countries through 2030. That combined spending falling far short of the minimum benchmark that the WHO has set to meet UHC goals, and the same on the right for low and middle income countries. These sort of declines and pressures on funding come at the same time as you have growing demands on primary healthcare. The dual burden of disease, you have increased pressure to respond to pandemic risks, you have climate change, epidemiological transitions, population growth, you name it, there is increasing demands on primary healthcare. So this all creates an environment where I think we can all agree that doing as much as possible with resources that health systems have now is vital. And that is really what this webinar series is dedicated to. Next slide, please. So responding to this context, this webinar series draws on 7 years of experience across 6 countries in particular: Burkina Faso, Indonesia, Kenya, Pakistan, the Philippines, and Uganda, where our team and partners have all worked with governments to strengthen primary healthcare financing under real-world constraints. We leverage models and recognize the excellent global guidance that comes from, for example, to name a recent publication, the Lancet Global Health Commission on Financing Primary Healthcare. In this webinar series, we're going to try to focus on a very grounded and practical level on what has been tried in countries, what has worked, and what remains difficult. And we're going to go through 4 interlinked priorities that our team and partners have reflected on that we think can all come together to try to answer this question of how to get more health for today's money. Today, we're going to start at the district or county level, asking how managers can more strategically resource primary healthcare with their existing resources, funding and non-funding resources. Then in the second webinar, we'll move to look at national purchasing programs and examine how coherent they are with primary healthcare goals and how they can be made more coherent to support those goals. The third webinar will examine fund flows from national to facility level and how alleviating bottlenecks, delays, and rigidities in decision-making authorities can shape what primary healthcare facilities can actually achieve. Finally, we're going to reflect on the principles from the first 3 series and apply that to something that is vital for primary healthcare, and that's medicines and supplies. So looking at opportunities for innovating and doing more in the financing of medicines and supplies. We believe that our experience has shown that each one of these is valuable on its own individually. They've all been, there's been experience with them very practically in the very recent past. We also believe that there's an opportunity to recognize them all together, and that if they can be worked on together, and if they can come together, particularly at scale nationally, they really have the opportunity to do quite a lot of good, even in the very tight fiscal environment that we find ourselves in now. Okay, next slide. So I'm very excited about our particular agenda for today, this first webinar on the first topic. We have structured today's webinar with two moderated panel discussions rather than formal presentations, and we'll have a goal of keeping the conversation grounded in our governments and partners' practical experience. In the first panel, we're going to hear directly from county-level health system leaders in Kenya, who are focused on what information managers have or don't have when they're trying to allocate and manage scarce resources, and some recent innovations in doing so there in Kenya. The second panel will then bring in national and global perspectives, including some particular examples from Indonesia and Pakistan. And we're going to highlight an opportunity that we believe exists to improve this strategic resourcing globally. We will have a brief poll in between the two panels. So get ready for a couple poll questions for all of you to bring in your perspectives. And then we'll close with some closing reflections. And we're privileged to have with us today Nirmala Ravishankar, Deputy Director of the Exemplars in Global Health team at the Gates Foundation. So looking forward to that. Okay, next slide, please. So we'll begin moving into our first panel. Throughout the webinar today, we're trying to do three things, really. We're trying to demonstrate some practical experience. We want to compare that experience with other countries. And finally, we want to talk about opportunities to apply it, scale it, et cetera. The first panel is really all about the demonstration. And then the second panel will do a little bit of both, the comparing and applying. Next slide, please. Okay, without further ado, it's my pleasure to hand the microphone and the floor, the virtual floor, over to my colleague, Felix Murira. Felix is the Country Director for Health Systems Insight in Kenya. Felix, over to you.
Thank you, Nathan, for that good background. So to basically set the context for this next conversation, I will provide a short background about our partnership with the counties of Isiolo and Makueni around the work on helping them to better use data to inform how they allocate their limited resources. Over the past 2 years, we began getting messages from the county management that they were in need of better data to help them allocate resources effectively, which were pretty limited, especially because the service data that is reported routinely on DHS2 doesn't often explain the entire story. For example, there was a surge in things like facility maternal deaths or decrease in antenatal care visits, but those were only visible at the level of service delivery data, and managers didn't have further information on exactly what was driving those trends. While they had the additional space to act, it wasn't always clear where service gaps were obviously and how they would be prioritized. And we noticed after a couple of discussions that was largely because they lacked visibility into key inputs that directly shaped how services were delivered at the local level. And those important things were put in very beautiful document, as you can see on that slide, that guided these counties on how they would track staffing based on workloads in their facilities, how they would track commodities, its basic equipment, infrastructure, and even operational funds. So together with those two counties, we came up with pretty simplistic mechanisms to collect that data routinely in a structured manner, and a mechanism to have it reviewed by senior county managers who are able to make decisions on how to allocate resources in more regular meetings, actually on a monthly basis. This meant that managers moved from just seeing problems in the data to clearly knowing what to fix and where to focus their limited resources. In this segment, we will hear directly from our county leaders, starting with facility managers, on the information they rely on and how better visibility into readiness data can support stronger decision making at the subnational level. So to start us off, I will call upon Patricia, who manages a health center. That is a level 3 primary healthcare delivery facility in Kenya, to speak to us a little bit about challenges in reporting and how things actually happen at the local level. So Patricia, if you can hear me, maybe can you start by telling us, before you got into partnership with HSI to collect data on staffing, supplies, equipment, and infrastructure, what types of information were you routinely required to report, and how much time did that reporting typically take from your end, if you can hear me?
Thank you, Felix. In my facility, I'm required to report a wide range of health service data on daily, weekly, and monthly basis. When I talk about daily, these are the updating and summarizing of totals at the end of the day. If I talk about weekly, these are the reports that are, for example, notifiable diseases, outbreaks that need quick disease surveillance intervention. Now, when we come to monthly reporting, these are the large amounts of all service data across service delivery points. For example, the number of patients seen at outpatient, the number of pregnant mothers attended that month. For example, the patient volume in special clinics and as well commodity status. This report takes 1 to 3 days in compiling. We have to extract this data from the registers, then hand over to the Health Records Information Officer, who now verifies this data to check whether it is correct, and then enters to DHIS 2. It takes this more time because of patient care versus the staffing level. Thank you.
Thank you, Patricia. So following up on that, just to understand from your own experience, what are the most important resource gaps at your level that constrain service delivery at your facility?
The major challenges or constraints that I face in this facility, one is drug stockouts, where now patients are forced to buy drugs from private pharmacies. Another one is staff shortage. The patient demand versus the workload. You will find that the key cadres, it is not as there is a gap as it is required by the what can I call it? The Employment Act. Then when we talk about, we also have issues concerning limited operational funds, where we are getting inadequate funding, making it hard for us to purchase essential and critical supplies. Again, we are also having challenges concerning lack of basic equipment. For example, a BP machine, which makes our work also very difficult. Thank you.
Thank you, Patricia, for that insight. Now, following on those challenges that you've just spoken about, can you share a specific example of how one of those resource gaps have affected service delivery at your facility, and probably an example of how you typically manage those kinds of gaps to ensure that you smoothly run operations?
For example, when I talk about staff shortage, these are the key cadres that are nurses and clinicians. You will find that if there is no required staffing, there will be long waiting queues for the patients. And this will lead most of the patients feeling dissatisfied because they have taken more time in the facility. And for us to mitigate this, we normally do something we call task sharing, whereby a nurse or a clinician can perform multiple tasks so that we can attend our patients on time. When we talk about drug stockouts, as a facility, we have a way of borrowing from nearby facilities with excess stockouts. Also, we always coordinate with our sub-county pharmacists. In case there is surplus in count store, we normally order and we get replenished. Thank you.
Thank you, Patricia. Now, before you begin more structured reporting on facility inputs that you've just mentioned, do you feel the information you reported before, which was mostly on service out data on DHIS2, helped county managers address the challenges that you're facing that you've just mentioned, or was it mainly for topward reporting requirements?
Yeah, before the introduction of more structured inputs, this data was useful for tracking performance trades and overall service utilization. But at count level, there was that limited value in addressing the root causes or problems at facility level. For example, if there is a drop down in numbers, for example, for the patients who are sick, the account managers, maybe they won't be able to know, maybe this has been brought up by shortage of the staff or the drug stockouts.
Fantastic, thank you. And finally, now thinking a bit about your experience of now collecting and sharing data, whether it's workload indicators or deliveries, for example. What information do you think has been most important for county managers to see in order for them to support you better? What do you think should be the bare minimum for them to see to ensure that all those issues that you're going through to ensure smooth operations in your facility is visible to your managers? Any data that you feel should really be a priority for them to see?
I think once we started reporting service readiness data, county managers have a clear now picture of our facility capacity and immediate gaps. For example, when we talk about staffing levels and availability, the county managers knows the number of clinician or nurses at my facility and the required number. So they will do additional staffing. They will also be able to track the current stocks and consumable, and they will be able now to restock or to have adequate supplies of these commodities in our facilities.
Thank you so much, Patricia. Now, that was facility level experience. Turning on to county managers, with me, I have Dr. Chomba, who is the County Administration and Planning Director in Makueni, and Dr. Kimathi, who is the County Chief Pharmacist, but also sit with the County Health Management team. Now, just for context, Dr. Chomba, can you start by telling us how many primary care facilities you oversee on a daily basis, and how is it to stay informed about what is happening across them? Dr. Chomba, if you can hear me.
Hi, Felix. How are you? Greetings to everyone.
Loud and clear, yes.
Yes, thank you. Thank you for having me here. So Makueni County is one of the 47 counties in Kenya. A county is basically subnational government. And in Makueni, we have 242 county-run health facilities. And the bulk of these facilities are primary healthcare facilities. So we have 180 dispensaries, which are level 2 facilities. We have 45 level 3 facilities, and we have 16 level 4s and 1 level 5. So primary healthcare facilities in total are 225 of the 242. So that forms the bulk of where we do our health service delivery. And Makueni is a rural county, not very big, not very small, 8,000 square kilometers. So for the county management teams and even the sub-county management teams, it's quite a challenge to make sure you are in touch with all the facility managers like Patricia, keeping track of what is going on. The road network is not so good. So, for example, during the rainy seasons, some roads are cut off. So it's quite a challenge to keep track manually of what is happening in all the primary healthcare facilities and all the health facilities in the county at large. Yeah.
Thank you, Dr. Chomba. Moving to you, Dr. Kimathi. Given the scale for a county like Isiolo, which is pretty vast geographically, so how many facilities do you oversee, and how easy is it to stay, in touch with what is happening across them? If you can hear me, Dr. Kimathi.
Yes, thank you very much, Felix, and greetings, everyone. Thank you for having me this wonderful discussion. Isiolo County, as you've rightfully said, is one of those vast counties classified and the arid and semi-arid lands. I oversee 55 health facilities, two of which are level 4 and one county referral hospital, hoping to get the status of a level 5. The distance between the facilities is about 50 kilometers, and with the poor road infrastructure and poor cell phone coverage, so you can see it's quite a challenge to keep in touch. We cover about, Isiolo County covers about 25,000 square kilometers. So you can imagine the kind of, the spread. And we also serve a population of about, give or take, 330,000. And Isiolo being one of those, one of the counties, transit counties to the north. Then again, we have a lot of influx and outflow of people coming in as, because of the major highway that crisscrosses all the way to Ethiopia. Having said that, then you can clearly see the kind of challenges that there are in terms of communication. So first of all, just to reach the facilities themselves becomes hectic because of the cell phone coverage. And we have to rely on monthly reports. And usually, in any case, we can only act on these reports at the earliest 45 days, meaning that then if we were to take any decision, then that would have been overtaken by the time we receive these reports. So mostly we rely on informal communication just to try and see how we can troubleshoot and make sure that everything is working. Thank you.
Thank you very much, Dr. Kimathi. So moving back to you, Dr. Chomba, before you begin collecting routinely the data on service inputs, on staffing, issues to do with electricity, water, and those are the basic inputs. How did you track key service inputs across those facilities, and what were the limitations of that information?
Thank you, Felix, for that question. My counterpart, Dr. Kimathi, mentioned of informal sources of information that we get from the facilities. So we've tried to bridge the gap from what is not captured in our routine monthly reports that are reported on the national health reporting systems by creating WhatsApp groups, for example, where we have the facility managers who report events as they come in. We've also tried to do reports, the facilities do reports, but all this is informal and unstructured. It leads to very subjective way of collecting information because a facility may report, rather may not report. We also rely on media reports. Maybe a politician has gone to a facility. They found something missing in that facility, and they go ahead and report it to the county team, and we get to know about it. So it's a very informal and not reliable way of collecting information. But that's what we were doing just to keep abreast with what is happening in the facilities. We also occasionally go to the facilities and do supervision and do reports after visiting those facilities. But even this is subjective because it depends on who from the team went to the facility. If it's a HR member or a manager who went to the facility, most likely that report will only entail HR matters and leave out the supplies part. So it's not a very reliable way of conducting business, but that's what used to happen. Yeah. Thank you.
Thank you, Dr. Chomba. So following up on that point, so to what extent did those systems, WhatsApp groups, and all this informal way of collecting this important data help you understand whether or not your facilities were service ready, if at all they did?
Yes, thank you for the follow-up question. So basically, like I've mentioned, it's a very subjective way of collecting information. And it depends on how active the facility manager is in reporting. It's not standardized. So even a facility that does a report may report on one thing. For example, they may say they don't have supplies. And at the same time, there's a building in that facility falling off, and they fail to report that. So it's not a reliable way. Basically, we had no visibility on how ready a facility is. For example, a facility like the one Patricia is managing, at the end of the month through KHIS, we end up knowing how many deliveries she conducted in that facility. But how she ended up doing the deliveries is left out. We don't have the input data. Maybe the only billing machine she had in that facility became non-functional in that month, and there is no way of collecting that information. So you find that the primary healthcare facilities who experience underfunding have very limited resources and no way of reporting that.
Thank you, Dr. Chomba. That's pretty insightful. Now, coming back to you, Dr. Kimathi, once you are able to routinely see, information that is fit for use on staff, infrastructure, equipment, and even supplies, what new insight did that reveal to you? And are there findings that surprised you?
Oh, yeah, thank you very much, Felix. Yes, I did. This was a report that showed our true pain points, very objective report, and the situation was very dire, especially staffing. For a long time, we sort of had ignored, in as much as we wanted the primary healthcare staff to give us outputs, we sort of neglected some of the key drivers towards the desired outputs. And one of the things when we sat as the CHMT is the County Health Management Team that sits at the county headquarters to look at the kind of data that is being presented. And we realized that our staff, there was a mismatch in terms of staffing. One, we saw that there was where there was a lot of workload, the staffing was not commensurate, and in some instances there were none. So quickly as CHMT, we redistributed the staff that were available to us at that particular time, so that at least we try to optimize the services. And then we also pursued with the same report, we utilized this as an advocacy tool to the county leadership And I'm proud to say that since we have now employed approximately about 176 nurses, nurses are the ones who man the primary healthcare facilities. And that has been due to the report that came to us. You might ask where the staff went. We have had staff who have exited the service through, of course, retirement and of course, other, looking for greener pastures. So we were not able to adequately follow up on that. And this report revealed that. As regards the equipment, basic equipment, looking at the slide that is projected, you can see in April 2025 till June, decade 2025, we have made some deliberate attempts to ensure that all the facilities are equipped with the basic equipments. And you can see that there's some, though we are not yet at 100%, you can see there's some, of course, positive movement toward 100%. And we hope in the few coming few months, we should be able to hit 100%. And of course, again, the other challenge was that we do not also maintain this equipment. And courtesy of this report, and thanks to Health Insights, Health System Insight, we are now able to, plan for routine replacement and of course, servicing some of these equipment. Over to you, Felix. Thank you.
Thank you very much, Dr. Kimari, and congratulations for actually acting on that data. Now, moving back to you, Dr. Chomba, what did you learn when you looked at the staffing levels against workload in Makueni?
Thank you, Felix. If you allow me, let me explain how we did the analysis of the HRH, Human Resources for Health. So prior to this work, we would assume, and rightly so, that the secondary and tertiary facilities require maybe more nurses than the primary healthcare facility, just because they have more departments, they offer more services. And so one would assume that that's why you need to put more effort in. But under using the workload indicator for staffing needs, which is the WISING, which is what we employed in this analysis, you take what services are offered, for example, in a health center. The nurse will do maybe triaging, she'll offer outpatient services, immunization. How long does it take to do that? Do the same in a secondary institution. Maybe on top of they do inpatient, they do bed care. And at the end of it, come up with the required number, for example, of nurses in the primary healthcare space and the secondary and tertiary institutions. So what that revealed is we actually have understaffing level 2 and 3 facilities, and we have overstaffing in our hospitals, which is the level 4 and level 5 facilities. And rightly, the reaction to this data has been mixed from the unions, from colleagues in these facilities. So we want to go to another layer. This was quantitative, we want to do qualitative. We've decided we go to the facility and observe, have informant interviews with the staff, just to validate the quantitative data. But ultimately, we need to move staff, nurses and clinical officers from the hospitals to the primary healthcare facilities. And this will end up even helping the hospitals. It will decongest the hospitals. So this is just an example of how objective data collection and analysis can lead to better decision making and better services, quality services to the people they are trying to serve. Had we continued with the subjective way, we would have continued doing things differently, and our outcomes would not have improved. So we are looking forward to employing this and continue this work so that even our budgets are aligned as per the data, what the data is showing us, having an objective way of leading healthcare in the counties. Yeah, thank you.
Thank you, Dr. Chomba. I think you've answered my other question, which would really focus on, what you think can be done by counties to use this kind of data to improve their planning processes. But I think you just mentioned that pretty clearly. So I will ask that question to Dr. Kimathi. So Dr. Kimathi, how do you see this type of service readiness information improving planning processes at the county level, knowing that, for example, the fiscal space is still quite constrained? Are there some ideas that you have on how counties can actually leverage on what you have done to improve their own allocation efforts?
Yeah, thank you, Felix. And yeah, I think initially we used to have, we would fight for resources subjectively with no evidence. So courtesy of, this kind of analysis and data, we then use it as an advocating tool. For example, in Isiolo, we were able to move our health products and technologies budget from a yearly budget of 125 million Kenya shillings to 310 Kenya shillings. And it's just because we had, an objective way of presenting our needs. And therefore, I think with this, a way of projecting factually your needs, then I think this data can be used to mobilize resources and to make a case for the health department and therefore inform also all the other processes of budgets, the budget making, and of course informing work planning and so forth. So I think that is important going forward, and I think it should be we should be able to the other counties should be able to borrow this from Makueni and Isiolo. Thank you.
Thank you very much, Patricia, Dr. Chomba, Dr. Kimathi, for sharing those pretty useful insights. I think what we are hearing is clearly that managing service delivery effectively, especially with such challenges as we have heard from the panelists, doesn't only need output data on service delivery, but also critical inputs that shape how services are delivered and even shape quality and outcomes of those services that are being delivered at that level. With that exciting conversation, I will now hand this over back to my colleague Nathan for the next session. Thank you very much.
Great. Thank you, Felix, and thank you very much to all the panelists. That was great. And I was taking notes of some really important points that you made, including this last one from Claver of a near more than doubling, I think, budget for commodities just from the objective data on those inputs being available, and some great reallocation examples too. So thank you. So we are now going to move to the second half of this webinar, where we're going to do some more cross-country comparisons and look at opportunities to apply these lessons more broadly. As our second panelists get ready, we would like to ask you all a couple of questions, though. And I'll show those here on this slide. And in just a second, we'll launch a poll. So the two questions are, please choose first which type of facility data in your country you think district or county level managers have the best access to. Service provision, HR, drug availability, cash on hand, equipment, or coverage and or outcomes data. Which ones do they have the best access to? And then the second question we'll launch separately is which type of facility data do you think would be most useful for district managers to strategically allocate resources? So two questions, and we'll just give a couple minutes for everyone to take this poll. And you should see the poll question pop up directly on your Zoom platform screen, and you can click one of the answers there. We'll give 30 seconds or so for this first one. All right, we'll close that poll. And I think we'll see the results here. Okay, so we see that service provision numbers is what most people, about 50%, are answering that they think districts level managers have the best access to. Next, it looks like a tie, human resources data, drug availability. No one choosing cash equipment. A three-way tie actually for second place with coverage and or outcomes. Okay, very interesting. Thank you for answering. Now let's go to the second question. Not sure if the second question, there we go. Okay. So same categories of answers, but now the question has changed to which data do you think would be most useful for district managers to strategically allocate resources? Okay, why don't we go ahead to see what answers have come in on this one? Okay, interesting. So still a good number saying that provision numbers are useful, even perhaps most useful for strategically allocating resources. But we now have a more even distribution across all the categories, number one, and a lot of people commenting that coverage and or outcomes data might be most useful for strategic allocation decisions. Great. Well, thank you very much. This was meant both to get insights from around the room and also as a segue to our second panel, where we'll hear some comparative experience from Pakistan and Indonesia, and an opportunity, we think, to take some of these lessons and apply them even more broadly. So without further ado, it's my pleasure to hand the microphone and the floor over to my colleague. He is Health Systems Insights Country Director in Pakistan, and that is Hassam Durrani. Over to you, Hassam.
Thank you, Nathan. That poll was definitely insightful, and I think it leads very well to our conversation with this panel. I think we have a really exciting and excellent panel to actually explore how we can strengthen decision-making with better service readiness data. Just to introduce the panel, we have Mr. Ali Jan Khan from Pakistan, who is a senior civil servant with more than 25 years of experience across multiple provinces in Pakistan. He has a master's in financial economics from the University of Oxford and has led performance management reforms in both health and education. From Indonesia, we have Eri Satyavan, a health economist and the country lead for HSI, advancing strategic purchasing reforms to strengthen primary healthcare financing. Our third panelist is Rebecca Potter, who is a strategic and technical advisor for health information system strengthening at the University of Oslo. Rebecca provides technical and programmatic guidance for a broad range of partners and countries that use DHIS2. And we have Dr. Elizabeth Vangia, who is an eminent public health specialist who has served in the Kenyan government in a range of senior roles, most recently as Director of Health Financing, and is presently working as a senior health specialist at the World Bank. Thank you all for joining. When we look at countries around the world, we see that a lot of them have output-related information systems, such as DHIS2, that measure the number of deliveries that have happened or the number of vaccinations that are there, but do not necessarily measure input-level visibility. And it's very challenging to sometimes infer what exactly is missing to improve these outputs, whether it is some HR that is absent, whether there are power outages that are causing outputs to fall or change. Is it malfunctioning equipment? Is it medicines and supplies? So my first question to you, Ali Jansa, is when we talk about service readiness, you have led reforms in Punjab setting up the Health Information and Service Delivery Unit, which looks at input level visibility for primary care. Can you tell us a bit about it, and starting with perhaps why you felt the need for it?
Thank you, Sam. So, as Government of Punjab and Pakistan, we do take a lot of pride in our Health Information Service Delivery Unit. And when the poll was put on the screen, and I was thinking about the question one, so I thought that if I was allowed to answer, probably my answer would have been all of above, because what is the biggest achievement of Health Information Service Delivery Unit after nearly 10 years of journey, that we are able to have all those things. Now, putting the things in context, I think health department in any country in general, and in a developing country in particular, also starts the first challenge of dichotomy of managing the tertiary versus secondary and the primary facilities. And a lot of emphasis, because of optics and media values and other firefighting reasons, goes to the secondary healthcare or maybe tertiary healthcare system, while primary remains slightly less attentive. So our attempt in Health Information Service Delivery Unit was to come up with a dedicated system, start with the simplest building block of the health system, which was either the primary health or the community health workers, and integrating them, collecting a lot of data. Now, when we were talking about it and we were building about this, honestly, we never had the exact idea how would it look like after 3 years or 2 years or 4 years. We started the journey in 2016, and over the period of time, the actual reason why systems were developed were the managerial decision. So one of the basic difference between HISDO and any other data system has been that HISDO also covered the managerial parameters in addition to the technical parameters. Like for each interventions, we talked about the talk about the immunization, we talked about the ILR or the temperature or all these things, but it was equally important whether inputs are there or not, whether uninterrupted power supply is there or not. So we divided them into input indicators, process indicators, and output indicators, and all these were covered. Secondly, I would say that and we allowed the data systems to grow organically. If there was some HR shortages issue, the need was actually driving our solution. And we were never about really was pushing for the best of the best solution. Rather, these were standalone solution, no integration was there. But we kept on collecting data and developing systems. And I call it as a centralized, decentralized system. In today's world, obviously, centralization is considered as an abuse. But I think in digital age, it is extremely important that the system compilation analysis shall be central, and we shall enable our district manager to tap into the central database. The data collection shall be district based, and all the data shared shall be district based and decentralized. Similarly, again, developing countries face a challenge of independent data collection. So we engage something like 200 independent data collection agents who went nearly on a fortnightly frequency to each primary healthcare unit. And then obviously our systems were responsive. We allowed the system to evolve with time. And I think another important component is the physical manifestation of this data system. We had a very beautiful, ultimately centralized system that was visible because it ensured the continuity from one regime, one political government to other political government. Otherwise, even with the change of government, people start forgetting opening the dashboards. So the timeline shows that from 2016 to 18, we developed maybe something like 30-40 systems. We consolidated from 2019 to 2022. And then 23-24, we did one thing. We actually rewrote the entire system, which means we developed the entire system on a common architecture. And ultimately, we take a lot of pride. We added secondary healthcare, we added tertiary healthcare. And last thing from my side, what this system is doing right now and what Punjab health department is doing right now, it's a department with a budget of nearly 2 billion US dollars. It has got more than 4,000 nodal points and HR of 300,000 people. Daily, it serves an OPD alone of close to 500,000 patients. So entire HISDU was capable of addressing all this. So, and then obviously all this was accompanied by a very rigorous performance management system routine. There were weekly reviews and monthly reviews, a monthly what we call as district health manager conference, hospital manager conference, where we provided them the data and asked them to explain the red areas within green areas and overall red areas so that we can understand. And it was a feedback loop. Based upon their inputs, we also provided them with the resources. So it's over to you.
Thank you so much. That's actually very interesting. So the way I understand it now is 10 years on from where it started, is now in a very advanced stage catering to this enormous profile that you just indicated. But when we talk about the possibility of initiating reforms in other developing countries or trying to sort of replicate such systems, I think there are two key important points that I've sort of picked up on what you're saying. One is that when it came to actually when it came to data, rather than it being self-reported, you use independent monitors who would basically check the facility inputs and then provide this data. And the second that I picked up was that you had monthly or weekly sort of check-ins or inspections or follow-up meetings that would then be used. So my question to you is that how was this input level data used for driving service delivery or improving service delivery in terms of empowering district managers as well as a tool of accountability?
Yeah. Thank you very much, Assam. You have very truly pointed out the two features, but I'll add one third feature of the data, that it was not compilation of numbers only. It was always patient level data. If it's immunization, it's the child's name that was there. If in case this is OPD, the patient name was there. If it's a delivery that has taken place, that was there. So using that, we were actually, and then obviously this was across input indicators, process indicators, and output indicators. And then ultimately there was a very rigorous performance management routine. Not only the accountability was done, but because whatever we say, while there is what we call as a one line transfer to districts or the sub-governance unit, but the provincial resources were also allocated based upon this performance management. And some of the systems, again, many of the participants in the earlier panel talked about the human resource shortages. Yes, in Pakistan, in Punjab, there are human resource shortages. There were human resource shortages. But I think a bigger issue was there was high absenteeism. So this system actually used the technology, the biometric machines were used. Now face recognition is being used. During the COVID, it discontinued for some time. So ultimately we came back with the face recognition and biometric devices, because if HR shortage is there, yes, it's a bad thing, but the government is not paying for that. But if a person is being paid and is unauthorizedly absent, then obviously we are wasting our resources, the financial resources. And this system enabled that from the provincial headquarters, we enabled our district health manager that during last 4 or 5 visits of the independent monitor, yes, this ex doctor was absent on 4 out of 5 visits. These were spot checks. It was not daily, but it can't be that over last 2 months, every second time or every 1 point second time, the person is absent or LHV is absent or nurse is absent. And we were able to throw names and we were able to hold them accountable.
That's very interesting. I'd like to now move on to Eri, exploring the Indonesian system. Eri, in Indonesia, local area monitoring has relied heavily on coverage data. Can you tell us a bit about it? And in terms of visibility, what is it available to the decision makers there?
Yeah, thank you, Hassan, for bringing this question. So I would say that we in Indonesia mostly do the management by performance, meaning that the way we record and report the data, particularly focusing on some indicators that is mandated by the central government or by regulation. So indeed, it was mostly related to the service provisions and coverage indicators like ANC, immunizations, and etc. I think this is aligned with what we just had in the polling earlier, I suppose. So there are some service readiness indicators monitored as an index or a composite value, such as the percentage of PHC facilities that has stock out of essential medicines and the completions index for medical equipment following to the Ministry of Health standards, but not necessarily in a very rigid mechanisms as for its line item consumables or equipments. So for the local area monitoring itself, particularly at the primary care level, I would say that they actually have run pretty well by doing the assessment routinely, even in a monthly basis for some priority indicators and looking at why some are not achieved, for example. But what we found in some district that it was less about how internal factors are contributing to the performance, which is the service readiness status. For example, the analysis that came out from the primary care level for low ANC rates was because the mother or family is XYZ and yeah, etc. Instead of looking at their supply set status. So the district health offices actually have access to separated information system like HRAs, consumables, or equipments, but unfortunately, it's mostly updated annually instead of in a monthly basis. So the use of it is very limited for routine monitoring system. Like what you can see in these slides that they actually have the visibility of this data for some priority indicators, but yeah, they know which one is increasing, decreasing, which one is having a problem, and etc. But the mechanisms to answer why and how this is happening, that's remain the challenge. So I think that's the current situations for our local area monitoring, Hassan, on what data is visible and the practices that has been done in the primary care level. But yeah, the challenges still remain in district health office and primary care level as well.
Yeah, so in terms of inferring input requirements, how do we sort of improve that from output level data? Do you think that the frequency of these input measurements, I think you mentioned a year, can that be improved for better decision making?
Yeah, thank you, Hassan. So the frequency is, I would say, important, but I think from the Indonesian situations, I mean, in our governance, it's not the only issue. So we had a chance to do a kind of mapping in 4 districts in Indonesia about the authority mapping in the district health office in which part of the service readiness component that can be controlled by the district health office itself. So as you can see in these slides that within this 4 category of service readiness, like human resources for health, facility, financing, equipment, and supplies, most of them are reported annually. It's just supplies or consumables that is reported in a monthly basis. But the most concerning issues that I can take from this assessment is that you can see the column for the DXO control that especially for human resources and facility financing, even the district health office has the budget. They're not the one who can, decide or have some sort of approval for resource allocations for from one facilities to another one. So I think this is part of the issues on how to decentralize the authority of the DSO for having these resource allocations, particularly for human resources and financing. And noting that in Indonesia, the primary care facility, or called as Puskesmas, most of them are the PLUD, which is the semi-autonomous status for controlling their own financing. But in fact, how they can manage their financing is not really autonomous. They're still controlled by the DSO as well. So I think this is part of the challenge on how we untangle the governance issue to boosting the mechanisms for resource allocations, particularly on the strengthening input parameters in district health office and primary care level.
So my question to you is, in the Pakistan example, we saw that how data was basically provided to district managers or basically driven to improve district performances. So in terms of the data that we have in Indonesia, when we look at, for example, the output data that you shared or the input data that you shared here, that is measured annually, are district managers aware of this data? Are they provided this information in a timely manner where they can sort of act, at least to the extent what they are empowered with? There are obviously challenges of HR, etc., where they can't do much directly.
Thank you, Sam. So, I think for the Ministry of Health is currently envisioning to integrate all these information system, like what I mentioned earlier, that HRH, supplies, financing. We already have the digitalized report, but it's still separated. So the Ministry of Health is currently developing an integrated information system, which is called by Satu Sehat. In addition, they are also developing a dashboard to monitor the progressions for integrated primary care in the field. I mean, in the primary care level, covering input, process, and output indicators. But I'm pretty sure that this deployment might take some time. So while waiting for that deployment, we HSI in Indonesia working with some districts, for district particularly, on how to build this performance management framework, particularly on how to redefine the ways of working on using the data in a monthly basis, and really looking at what things that is still concerning, why that happens, and what course of actions that can be taken at the primary care level. So these figures, you can see that this is just one example of quadrant analysis that we work with four districts, looking at which Puskesmas or primary care level that performing not quite well, given the big or enough resources in the red highlights. So in these situations, the district health office did some sort of one-on-one discussions with them, looking at why it's happening, and then do some sort of prescriptions on the course of actions that can be taken in these two Puskesmas. So the other things that we are also working with district health office is also having lesson sharings across facilities, because we believe that it's not only best practices that needs to be shared to another, but even the worst things, like what we are looking at these slides, can be lessons on how the other facilities, if they met these kind of situations, what kind of things that they can manage by themselves, given the limited resources, scarcity of financing, on etc. What types of alternatives that they can make in the primary care level. So yeah, again, what they are currently prioritizing is the indicators that is mandated by the Minister of Health or by regulations, but then how they can manage the resources like HRH or financing. It's really depends on the district health office or the district governments managing their own resources. So yeah, I think this figures is helping them just to improve the visibility of the data and how to make some sort of actions for these issues.
Thank you so much. I think you're spot on the importance of trying to use any kind of performance management indicators to drive change. Rebecca, I'd like to move to you. You're working on the HFP pilot, which is sort of a higher frequency, lighter touch assessment tool, in contrast to older assessment tools such as SARA and perhaps harmonized health facility assessment, which were used over an extended, perhaps over a 5-year cycle, being more resource intensive and be for planning purposes. Can you tell us about the HFP pilot and how that will improve, for example, service readiness?
Sure, thank you, Hassam. So I think as Felix and Patricia and Dr. Choma and Dr. Kamathi have all mentioned, there is a very clear need for this data, particularly at the subnational level, the district level. And generally, we're already able to reference these national DHIS2 HMIS systems as performing reasonably well for your routine service delivery for notifiable disease surveillance. Of course, there are issues with timeliness and quality, all these types of things, but it general functions quite well. But then we're missing this kind of level of having the health input data. And I think what's interesting here is that this data is not especially difficult. It's not more difficult than the routine service delivery data that is also captured. But there's a big question around like, why hasn't this been happening systematically and at scale in the same way that HMIS systems have been set up to capture the reporting at the lowest level, but also to fit the analysis needs at the lowest level from the facilities to the districts and then moving all the way upwards. And so I think what's interesting, this health facility profile module that we have, we developed a couple years ago with very, very limited funding from the Global Fund. It actually came out of the pandemic, where a lot of countries, these gaps in their systems were very visible. They did not know where there were beds, how many beds, availability of essential equipment. So in addition to this primary healthcare lens, there's also a bit of this emergency preparedness lens. And I think, this type of data, does it not exist? What are these gaps? And I think many of our colleagues on this call have pointed to a lot of them, is that these systems, they might be set up as surveys, they might be fragmented, they might be program specific. We're also seeing a lot of duplication of the same asks for this type of data from facilities in one-off assessments and surveys. And it's clearly not suitable for routine operational use at the district level if you manage the data in that way. And so what we're seeing as most useful is this availability of essential services, medicines, equipment across facilities, the availability of trained workforce, personnel density also by cadre that was mentioned here. There's a really big opportunity, but also use of the triangulation with the routine service data. And that can really help you to identify gaps, but also things that might be going wrong. If you have facilities that are reporting a lot of services where actually you find they don't have the equipment to deliver those services, or maybe they don't have the staff. So I think being able to identify on an operational real-time basis, and real-time as in monthly or quarterly, is really the sweet spot here for being able to make progress. I think the last thing I will say, as areas noting in Indonesia, these fragmented, these kind of parallel systems, the frequency of data and access, to make this data really usable, it really needs to be developed. In coordination with all of these different actors that we've actually seen and heard presented here today from the facility with a focus on the district needs. When you look at these every 5-year surveys, they're very expensive. In places like Ghana, they don't cover every facility. So you actually can't really make many operational decisions based on the HHFA. They're also very long. They're 2,000 questions. They require external validation. So it's a very valuable data source, but it is not serving the needs that we've heard from our district managers here today. So I think that's sort of co-design around what type of data is feasible to collect and really thinking about the 1 to 3 days it takes facilities to prepare their routine reporting on top of everything else they have to do. And working very closely with the district managers as well to understand what can actually change and how do we actually relieve these bottlenecks for the facilities. So a lot of this work, I think now we have a catalyst with primary healthcare lens. I think a lot of the fragmentation has unfortunately been a result of siloed systems across vertical health programs where you see duplication, you see lack of sharing. But I think in addition to emergency preparedness and also bringing facilities up to speed on climate resilience, we're going to continue to need more types of this data, this same but different data, right? And so we need a flexible system that can be long-term, it has access, it has visibility, and really making sure that that system is being built and designed with the lowest level users. So I will go ahead and stop there. But maybe to leave you with a nice little piece of impact. We have lessons to learn from programs. So there's been a lot around, availability of medicines. There's huge investments into electronic logistics systems. These typically don't reach the facility level. And yet district managers, many times they still don't know at each facility how many vaccines are left, how many are not expired. They're the ones that actually have the ability to move and shuffle this stock around between facilities and respond in real time. And so in Nigeria, what we saw, immunization programs have been quite ahead because they have tracked their vaccines and wastage and medicines very carefully as a programmatic focus. But this can apply to any essential medicine. And when they had the dashboard set up, monthly reporting with the LGA level, which is like a county in Nigeria, the right people being trained, so the logistics people as well as the immunization focal point at those district levels, they were actually able to reduce stockouts by more than 5,000%. So from 10,000 facilities reporting stockouts per year to around 388. And that's through a basic monthly report that can be integrated. So I think we have huge opportunities here, but we also have many challenges around how to bring this specific type of input data together and make it usable alongside the routine service delivery. Over.
Yeah, I think that's very, very interesting. So my follow-up question to you here is that given the prevalence of DHIS2 around the world, it's very nearly every country has it. What would it take in terms of appetite? Is there appetite for health facility profile to be integrated into that? And what are, for example, the conditions that you feel would be necessary? Like you mentioned, the challenges with actually input of that data. What conditions are required for this to be taken up?
That's a really good question because I think technically this is not a heavy lift. And also compared to these incredibly complex national scale systems that all countries are working on, when you think about logistics systems, supply chain, this type of data management is reasonably straightforward. So it does beg the question, if we have DHIS2 and we've scaled up reporting to all of the facilities, then what other prerequisites are needed to take advantage of this platform essentially as digital infrastructure and make it serve more of the needs of the district level health managers. And I think my short answer is governance and having a really strong plan. So I think we know that there is definitely willingness, and these types of approaches, they actually came from countries before they came to us. So before Global Fund even came to us to ask about this as well, countries like Laos had actually taken the mini SARA survey, the service availability and readiness assessments, precursor to the much bigger HHFA. They made a mini survey into their routine HMIS. They scaled it up very quickly. It was very cost efficient because they already had the infrastructure and they were able to give the instructions for the reporting, and they monitored it, and it did really well. And they continue to do this about every 6 months. And they've also just expanded that module to conduct their kind of first assessment across all of these facilities on climate resilience facility level indicators. So just to demonstrate how flexible it can be, but it can't be done unless you have a strong coordinating unit and a governance body. So someone has to take control and ownership and have the mandate for managing this data, managing the system. But there's also the data generation and the users themselves, and those are not always the same people. So really having a strong plan that this can be a part of national infrastructure, but it still is owned and used primarily at these decentralized levels, I think is a little bit of that sweet spot. And I think the colleague just before me said, centralization, it feels like a bad word, but I think in information systems, this actually can be very empowering if you set it up with the flexibility and the mechanisms to make it work for the end users, the one who are generating the data, and give them the same level, often more access and flexibility to use it. And I think the last piece, yeah, I talked a bit about just program fragmentation. Where do different funding sources sit? But I think more on a happy note, places like Uganda, they also have a DHIS2 national system that runs as their national health quality improvement information system. So it's its own instance of DHIS2, but it connects with the national HMIS. And when we piloted this particular module, we built it on to that quality improvement system that already exists. It works in Uganda. It doesn't work perfectly. But we also had to do a lot of time kind of spending to understand how is this different than the really in-depth quality improvement surveys that are done? What types of things require external verification, supervisory visits, versus what types of data is appropriate for self-reporting? And I think the magic is really identifying those units, those workflows, those mandates, and then kind of figuring out a system that can work together over.
Yeah, absolutely. Thank you so much. I'd like to move to Dr. Vangia. We're slightly behind schedule. Dr. Vangia, you have experience as part of government where such input level surveys have happened, and you've seen them being utilized. I want to ask you, now that you're on the other side of the table in trying to support governments in strengthening health systems, do you feel equipping decision makers with tools that target service readiness and facility readiness data without having a prohibitive cost such as the SARA survey in terms of resources is something worth aiming for?
Yes, so thank you so much, Hassan, for the question. And indeed, what you're raising is quite pertinent. If you look at an example like Kenya, we generate a lot of data, and most of this data, despite the fact that the health system in Kenya is devolved, one good thing is that the health information system was not devolved. However, if you look at the usability of the data, we still have challenges in its use at the point of generation. So at the point of generation, most of the data is, and the reporting is probably mainly for compliance. Like at health facility level, you'd find, and we have heard even from the previous panelists, that most of the either facility in charge, or if there is a health records and information systems officer, they aim or they target to report, say, by the 5th of the following month. And after reporting, I think to them, it seems like it's a box that is ticked, and they are good to go. They can now focus on other things. And really, that's not the purpose of data. Data is actually meant to inform the people who actually generate that data. Now back to your question on such service level data, for instance, input level data, human resource, HPTs, health products and technologies, infrastructure, equipment. All this data should actually be used by the primary generators who are at the facility level. And if they use this data adequately, then there are even higher chances of them advocating, say, if there are high workloads, they could actually use that data to maybe speak to their management and tell their management, okay, you see here we have we see these numbers vis-a-vis these inputs in terms of human resource, HPT, and equipment, etc. So yes, such data is very critical. Unfortunately, such data is not collected on a routine basis, and I'm really excited about the work Rebecca has done, because such information, as much as it's not, we don't want it real time, like on a daily basis, but such information, even on a monthly or a quarterly basis, could really come in handy to help in decision making. You have talked about the facility assessments, the SARAs, the HFAs, harmonized health facility assessments. Some of these assessments are good, but they are quite costly. Therefore, you get the results 5 years down the line, and by the time you are prioritizing within those 5 years, maybe an intervention happened, and therefore whatever findings are there are no longer relevant. So, getting a modality of having such information reported, one, in an affordable way. Remember, the theme of this webinar is also more health for the money. So we are thinking of how can we do it in a more affordable manner without burdening the clinicians. The clinicians, we know at primary level, you have very limited clinicians. So how can you do provide such information without burdening? And sometimes the more you report, you may actually also compromise on quality, because then someone decides just to report for the sake of reporting. But then if it's a bit more structured, that's not really burdening to the provider, then even chances of getting quality information are very high.
Yeah. Yeah, so I think you're making some really good points, particularly around the quality of the data, the availability of that data to the users of those facilities, and then also that they have to be not prohibitive in terms of cost, in terms of the time lapse that you mentioned, as well as the affordability in general in terms of burden. So I think we've gotten some really, really interesting insights from our panelists here, particularly on the utilization of the data, on how it can be applied, and how this can be scaled up as well to multiple countries. So I think I'll hand it back over to Nathan. Thank you so much for the panelists.
Thank you very much. Great second panel. And thank you, Hassam, and all the panelists for that. I also want to thank all of you for asking some great questions in the Q&A box. I think there was at least 8. And thanks to my colleagues, Matt Boxshall and Felix Marira for answering the questions in that Q&A. We'll capture those and be sending them out afterwards. I'm afraid we've squeezed our closing remarks speaker into a very short amount of time, but I think we can go over a minute or two. It's my pleasure to hand over for just some closing reflections to this first webinar to Nirmala Ravishankar. Nirmala, over to you.
Thanks, Nathan. I feel like you've done some of my job already, which is, of course, to thank everybody, the panelists, the audience that has both made time for this webinar and interacted very actively in the chat. And then, of course, the HSI team that organized all of this. So thank you from my side as well. I guess in the remaining time, I just wanted to highlight or pick out 5 key points that I took from the discussion. One, when the foundation first started working on performance management as part of our work on primary healthcare, we were sort of entering uncharted territory for us. And what I'm hearing from the evidence presented here, especially from Kenya and Pakistan, the value of performance management, both for visibility, so bringing greater visibility of data, and that leading to both greater accountability as well as better resource allocation, right? So both those functions being a big part of this agenda. Second point, use of the data, right? And so there was this interesting juxtaposition of centralization versus decentralization, which Ali Jan talked about, right? So decentralized collection, but centralized analysis. But then when it comes to use, we would want to see it at every level in order to incentivize better reporting, as well as all those virtuous functions that we want to see, whether it's accountability or better resource allocation. Third point for me was around matching visibility of data with authority. And I think authority to act and the decision rights to act on the data. And I think that came out really clearly from the presentation from Eri, this mismatch between what DHOs can see versus what they can act on. Fourth was this interesting sort of conversation about accuracy and quality of the data, right? So especially for our Kenyan colleagues, this data is now giving you greater visibility, but it's self-reported data. So what kind of additional mechanisms or opportunities are there to test some of it, test the accuracy of the data? Is it through supervisory visits? Is it by perhaps triangulating between surveys like the SARA and the mini SARA versus what data is being reported on a routine basis? And then maybe a final point is just about the burden of data collection, right? So we heard from Patricia, she reports data on a daily, weekly, monthly basis, and it's a lot of data. And so now, of course, integrating service readiness data into existing HMI systems will certainly help, but does Kenya really need, or do those counties need 40 indicators, or can they be streamlined? What are other solutions, digital solutions that may streamline the collection of the data? And in this day and age, in this moment, I feel like I'm required to say, can AI help to solve some of either the data reporting needs or technology like optical OCR technology could perhaps be helpful as well. So throwing that out as the fifth and final point, and with that, once again, let me thank everyone, and thanks, Nathan, for inviting me and giving me this opportunity to both listen and share my reflections.
Brilliant. Thank you so much, Nirmala. And you did it in even less time than we had told you to prepare for. So I appreciate that. This has been fantastic. I think lots of great points made here on the need, on some practical experience that shows promise, and then also some really great opportunities actually to institutionalize, to apply, to scale up some of what we've been talking about here today in many countries. So thank you for that. I want to thank also finally our colleagues who have been in the background here, but from Impact for Health International, who have helped us develop this webinar series and have helped make some of the magic work behind the scenes. And we're capturing Nirmala's points there live as she spoke them. Please do register for our following webinars. So we've got the second one coming up. It'll either be late April or it might slip into early May, given some conflicting events that will focus on the coherence of national purchasing programs, both national health insurance and other kinds of purchasing programs for primary healthcare goals. Later in May, how fund flows down to facility level shape PHC, and then finally bringing this all together with the vital importance of medicines and supplies financing. So thank you very much. There's a QR code there to register for our newsletter, which will make sure you get an invite, a specific Zoom invite for the next webinar. Thank you very much, everyone, for joining us. 90 minutes is a lot of your time, and I greatly appreciate you giving that to us today. Please be in touch if you have any follow-on questions. We will share out to all registrants the recording of the webinar, as well as the Q&A exchange and some associated products that you may like to check out. Thank you very much. Bye-bye.